Alright, let's study. Whoever's watching this, day 2. Left off at S3. Let me know if you want this PowerPoint. I'm gonna revise it as I keep studying. Let's see. I think I left off here, right? Yeah, alright. Let's see, last thing I said was S3. So what are the common clinical presentations that can occur with a dilated cardiomyopathy? Can occur with a dilated cardiomyopathy. There's an S3, which is early ventricular filling, normal in children, ventricular systolic failure. Okay. An LVRV heave. Excuse me. Excuse me. And that's, I googled that. I googled LVRV heave and it gave me parasternal heave. So this is an impulse that can be palpated with cardiac or respiratory disease, and it's visible pulsations of the chest wall. Okay. Other presentations that could occur include mitral or tricuspid regurgitation, which is when some of the blood spills backwards because the valves aren't functioning properly. Jugular venous distension, which are visible jugular veins. Rales, which is an abnormal rattling sound in unhealthy lungs. Edema, swelling, low voltage on EKG, and signs of cardiomegaly by CXR. So EKG, if I remember, I can't remember the PQRST. So atrial depolarization is in the P section, which means the atriums are contracting. Atrial depolarization initiates contraction, right? The ventricles depolarize at the QRS complex. And I also learned that atrial repolarization occurs during this time too, in the QRS section. And then the ventricles repolarize at the T. Okay. Cardiomegaly is enlargement of the heart, and CXR stands for chest X-ray. Okay, yeah. I wrote it here. What are the physiological aspects of restricted cardiomyopathy? Restricted is stiffness of the heart. Normal systolic contractility. Okay, so it contracts normally. Reduction in diastolic relaxation. Okay, that makes sense. And filling capacity. High LV and diastolic filling pressures. I think that makes sense too. And high pulmonary wedge pressures, especially with exercise. Okay. What are the common causes of restrictive cardiomyopathy? Most are idiopathic, or they occur spontaneously, but other causes include infiltrative diseases such as sarcoid and amyloid. So sarcoidosis, they're collections of inflammatory cells in parts of the body, and they tend to build up I think I did something wrong here. Sarcoidosis. Lymph node growths commonly occur in the lungs, lymph nodes. Yeah, there's something wrong here. Okay. It says amyloid here. I gotta revise this. Oh, just this one. Okay. Growths occur, commonly occur, symptoms vary, organs affected. It goes away on its own. Okay, here we go. Now we're good. Okay. So sarcoidosis. Wait, actually, wait, tiny collections of inflammatory. Okay, alright, cool. They commonly occur in the lungs, lymph nodes, eyes, and skin, and they vary depending on the organs affected. Okay. Amyloid is abnormal protein usually produced in the bone marrow and can be deposited to any tissue or organ. The symptoms depend on which organs are affected. Yep. Swelling, fatigue, weakness, shortness of breath, numbness, tingling, or pain in hands. Okay. Depending on the types of amyloidosis, medications, chemotherapy, or stem cell transplant may be options. So there's multiple ways to treat. Okay. Storage disease. Let's see. And storage diseases, for example, hemochromatosis. So storage disease is it's like a accumulation of storage material within a cell, such as hemochromatosis, which is when the body builds up too much iron. Okay. Other potential causes include radiation exposure and cancer. Okay. What are the common clinical presentations associated with restrictive cardiomyopathy? Symptoms are similar to dilated cardiomyopathy, fatigue, exertional dyspnea, which is difficulty breathing, or orthopnea, or difficult breathing when you're lying down, but gets better when you're sitting up, but could be present with syncope or fainting, near syncope, and palpitations. Palpitation. That just means palpate, right? Oh, heart palpitations, heart racing, pounding, or fluttering. Okay. I should probably write that down. Storage disease, blah, blah, blah. Where was I? That's gonna be outflow tract obstruction. Okay. I think I'm here. Palpitations. 12 neuron. Okay. Restrictive cardiomyopathy is more likely to have an S4 associated with stiff, low compliant, as opposed to S3. Okay, so S4 is associated with stiff, which makes sense because, okay. And S3 is early ventricular failure associated with ventricular dilation. S3 is associated with ventricular dilation. Okay, and S4 is associated with stiff, low compliant ventricle. Okay, yeah, that makes sense. Symptoms often present with a resting tachycardia and typically will not show signs of cardiomegaly. Oh shit, am I reading? Yeah, okay. Okay. What is hypertrophic myopathy? Am I done? Oh. So what is hypertrophic cardiomyopathy? It's a disorder. It's a genetic disorder resulting in abnormal hypertrophy or thickening of the ventricular walls. It often results in asymmetric. Okay. Hypertrophic changes which can create outlet obstruction. Outlet obstruction is when outflow is blocked or obstructed. Okay. Typically, there's normal LV systolic contractility, but increased diastolic stiffness resulting in reduced LV filling volumes. Okay. Patients often present with high pulmonary capillary wedge pressures and pulmonary hypertension. Okay. So pulmonary capillary wedge pressure and pulmonary hypertension. I think they're talking about the pulmonary branch. Pulmonary hypertension. Pulmonary hypertension affects arteries in the lungs and the right side of the heart. Yeah, okay, that makes sense. Okay, yeah, I remember correctly. Let's see what else. What are the common clinical presentations of hypertrophic cardiomyopathy? Young patients, clinical signs, symptoms, difficult with compliance of palpitations. Okay, chest pain. Okay, wait, let me remind myself what palpitation is. Racing, fluttering. Okay, yeah, chest pain. Makes sense. Dyspnea, difficulty breathing, syncope, dizziness. Okay. Sudden death is not an uncommon presentation. Oh, okay. Resting tachycardia is common. Okay. What are the key management options for patients with hypertrophic cardiomyopathy? For patients, okay. Patients may be advised to avoid physical activity, avoid preload, afterload, reducing agents. And I didn't know what that was. So preload and afterload. Preload is the stretching of muscle cells prior to contraction, okay? Afterload is the force which the heart has to contract to eject blood, okay? So you don't want reducing agents. That makes sense. And positive inotropes such as digoxin. So positive inotropes, they strengthen heart contractions. Okay. Beta blockers, calcium channel blockers may be used to slow the heart rate. Wait, beta blockers and calcium channel blockers may be used to slow the heart rate. So you want to, okay. Myomectomy is surgical removal of fibroids from the uterus, which is common, non-cancerous growth, okay? They usually develop during childbearing years, okay? Where am I? Okay. And septal ablation by catheter or chemical means may be needed to decrease outflow tract obstruction. So septal ablation is when they insert a catheter through the blood vessel from your groin all the way to your heart, I believe, and they insert an alcohol that's toxic so it can thin out the thickened heart muscle, okay? And then they'll take it back out of your body, okay? Okay. ICDs, they're battery powered and they keep track of your heart rate. If there's an abnormality, it'll deliver an electric shock so your heart can beat normally again. Okay. Also, okay, are considered because of increased risk for ventricular dysrhythmias. Dysrhythmias are also called arrhythmias in these patients. Also, the immediate family should be screened for undiagnosed individuals at risk. The immediate family. Okay. I'm tripping. I'm trying a little hard to focus right now because I just finished class. A little tired. Okay. Also, the immediate family should be screened for undiagnosed. Okay. I got it. Because it's genetic, right? Excuse me. It's a genetic, yeah, it's a genetic disorder. Okay, all right, cool. Whew, a little hard to focus right now. Okay, myectomy, dysrhythmias. Okay, so I gotta find where I left off. Okay, conduction disorders. What are the common causes of multifocal atrial tachycardia, aka MAT? So what is that even? So multifocal atrial tachycardia is when arrhythmia caused by multiple sites of competing atrial activity. Okay. It's characterized with an irregular atrial rate of greater than 100 beats per minute. So common causes are chronic obstructive pulmonary disorder, congestive heart failure, sepsis, valvular heart disease, and methylxanthine toxicity. Methylxanthines, they're produced both naturally by plants and animals, and they're used to treat airway obstruction. Conditions caused by conditions such as asthma. Okay. If necessary, treat a stable patient with chemical cardioversion by using a class 1A or IA agent, such as porcinamide or quinidine after digitalization. Wait, where did I get verapamil? Why did I put it all up here? So cardioversion is restoring normal heart rhythm for certain types of abnormal heartbeats, such as arrhythmias. It's done by sending electric shock. Okay. Using a class 1A agent, and they're talking about antiarrhythmic agents. Okay, quinidine, porcinamide. If this treatment fails, or if the patient's unstable, electrocardiovert to from 25 to 50 J. What are some causes of atrial fibrillation? Atrial fibrillation is irregular heartbeat, hypertension, rheumatic heart disease. I forgot what that is. Rheumatic heart disease. Where did I write that? Rheumatic heart disease. It's a condition. Oh yeah, heart valves becoming damaged by rheumatic fever. Okay. So what are some causes of atrial fibrillation? What causes abnormal heartbeat, hypertension, rheumatic heart disease, pneumonia, which is when fluid fills the lungs, thyrotoxicosis. It's the manifestation of excess thyroid hormones due to inappropriately high circulating thyroid hormone concentrations. Hyperthyroidism, subset of thyrotoxicosis. Oh, thyroid hormone action. Okay, refers specifically to excess thyroid hormone synthesis and secretion by the thyroid gland. Okay. So how the body normally works: your brain sends signals to an organ and tells it to make hormones. I think the brain sends a hormone to tell the thyroid to, wait, let me see. Thyrotoxicosis. What is the difference? Yeah. It's characterized by increased thyroid hormone synthesis from the thyroid gland, whereas thyrotoxicosis is a clinical syndrome of excess circulating thyroid hormones, irrespective of source. I should add this one definition. Okay, I'm gonna add this one. Okay. Characterized. Okay. Ischemic heart, which is ischemia, is lack of blood flow in the heart. Pericarditis, which is like inflammation around the lining of the heart. I think the pericardium. Swelling and irritation of thin sac-like membrane. Yeah. Okay. Ethanol intoxication. PE, which is pulmonary embolism, which is sudden blockage in a lung artery. Okay. Okay. Congestive heart failure, valvular heart disease, and COPD. How is atrial fibrillation treated? So how is atrial... Okay. Control rate with beta blocker or calcium channel blocker, such as verapamil or diltiazem. Wait, so if you want to treat irregular heartbeat, you control it with beta blockers, which also control blood pressure. It's an antihypertensive too, right? Beta blockers, make us reduce your blood. Yeah. Okay, let's see. Control rate, and then convert it with prosinamide, quinidine, or verapamil. Digoxin may be considered for rates that are not controlled with typical first-line drugs. All its effects will be delayed. Wait, digoxin may be considered for rates that are not controlled with the typical first-line drugs. Oh, although its effect will be delayed. Okay. Oh, okay, I get it. So it'll take longer to take in effect. Okay. Synchronized cardioversions at 100 to 200 joules should be performed for an unstable patient and a stable patient with atrial fibrillation of unclear duration. Anticoagulants or blood thinners, aka longer clotting time, should be considered for 3 weeks prior to chemical or electrical cardioversion. So synchronized cardioversion should be performed. Okay, and in a stable patient, unclear duration should be considered prior to. Okay, so you can cardiovert chemically too. Okay, a transesophageal echocardiogram is commonly used to determine timing of cardioversions. So, a transesophageal echo test. you put a tube into the esophagus, so I'm guessing it goes from the mouth to the stomach, and they let you see pictures of the heart without the ribs or the lungs getting in the way. Okay. Commonly used to determine timing cardioversions. Watch for hypotension with the administration of negative inotropes. So negative inotropes, they weaken heart contractions versus positive inotropes, which strengthen heart contractions. Okay. Negative inotropes, they slow heart rate. Okay. Alrighty.